מבקש להזמין את דוקטור דונה שכבר שמעתם מפאולה את מעלותיה, מנהלת תחום המיאלומה נפוצה במרפאת פרינסס-מרגרט בטורונטו, קנדה, ומחקרים רבים, להרצאתה הראשונה.
Thank you very much. It's a pleasure to be here, and I apologize that my Hebrew is very weak. But I would turn around what Paula said is that we can learn a great deal from Israel and from Amen, which is an incredible organization. And I commend your efforts because in Canada we have many good things, but we don't have funding routinely for carfilzomib yet. So I think you've been able to accomplish a great deal by getting all of the potent drugs available. What I'd like to do in this session is to discuss a number of aspects of relapsed and refractory myeloma, because although experienced a good long first remission, basically at some point everyone has to face the prospect of the disease recurring. And myeloma is a disease that is controllable, and there is much that can be done on the back end of treatment. And I'm going to try to walk you through some of the options, and this will have a Canadian slant because our country and our funders of healthcare are very evidence-based. The quality of the evidence to support a treatment has to be quite strong. So I tend to emphasize phase 3 or randomized trials that are designed to establish the superiority of one regimen over the other. But I'd like to begin by a few slides that highlight key features of the biology of the disease. I think people living with myeloma these days are very sophisticated and know that is not one disease. Dr. Geiger has already alluded to this. And even though under the microscope the cancer cells may look the same, when you do more detailed tests based on chromosomal patterns or molecular features, there are at least 7 different subtypes, and they do have different biologies. And as Dr. Geiger said, the goal is eventually to define the best therapy for each subtype, personalized medicine. Secondly, and I won't belabor this now, but when I talk about new drugs, I think it's important to keep in mind, as shown in this cartoon, this is the myeloma cell, and it does not exist in isolation in the bone marrow, but it is dependent on these supporting or stromal cells that maintain the network of cells or the stability of the cells in the bone marrow. And actually the interaction between these cells physically touching triggers a release of a variety of fertilizers, if you will, or small chemicals that interact on the surface of the cancer cell. And you don't have to know all these steps here, these chemical reactions, but this drives myeloma cell survival, prevents cell death, drives proliferation of the tumor. So one way to think of exploiting this system is that older chemo drugs are like poison. They kill the cancer cell, but some of the newer drugs disrupt this cell-to-cell contact, disrupt this release of chemicals or mediators that feed the tumor growth. And I will come back to this at the very end to show how some of the newer smart drugs have been designed and are being studied to try to really get at the heart of the problem here. The third point I would make about the biology is myeloma can be sneaky when it relapses. And I've shown this in these 3 slides. The majority of patients at diagnosis will make a whole antibody. It has a heavy chain and a light chain. And this is the M spike, or the paraprotein, or the monoclonal protein that's picked up on a serum protein electrophoresis. At recurrence, the myeloma cells can forget how to make the heavy chain and just make the light chain. And you have to do a different test to pick up this increase in a change in the tumor marker, if you will. You have to either do a 24-hour urine or preferably measure the serum-free light chain level. We also certainly are seeing patients more frequently that at recurrence the myeloma cells have forgotten to make both the heavy chain and the light chain. They've lost their tumor marker, and I think we have to be very vigilant that if new symptoms develop that could be related to myeloma, worsening anemia or bone pain, even if there's not a rise in the light chain or M protein, one has to be concerned or do investigations to see if the disease has progressed. I think it's fair to say that all relapses are not the same. Certainly, a patient can have a rise in the myeloma protein in the blood and urine and feel perfectly fine and have none of the stigmata of active myeloma, particularly bone damage or anemia. And our policy is usually to observe in this situation. Sometimes the myeloma protein will stabilize, but there are some arguments that can be made or have been made to treat early. That's not something our center routinely does. Relapses may be fairly slow and well behaved, if you will, or they may be more aggressive and rapid. There's also a recent concept that I think explains some of the things that we've observed clinically, explain them of what's going on with the myeloma population in the bone marrow. And we now know that at diagnosis, there are 3 to 5 different myeloma subclones in the marrow. And these are shown here, represented, each clone and its frequency is represented by a different color in the pie diagram. And with treatment, different clones are driven to predominance to account for different relapses. And these clones, you can imagine, may have different sensitivity to drugs. They may have different capabilities of making the heavy or light chain. But it raises the possibility that if a clone that was sensitive to a drug here is then suppressed, may come back here, you might be able to recycle a drug that quit working before. There are other hypotheses that have been proposed for how to deal with this clonal tiding, but I think it's a fascinating discovery that has changed how we think of the dynamics in this disease. Now I'll move into treatment a bit, and this is our armamentarium for treating all phases of the disease. We have a class of chemotherapy drugs called alkylating agents, which are either oral melphalan or oral cyclophosphamide. And a stem cell transplant is really a way to give very high doses of melphalan safely, and the stem cell support gets the healthy marrow grown back quickly. We have corticosteroids, dexamethasone or oral prednisone. Of course, we have the new first proteasome inhibitors, now second-generation proteasome inhibitors, and the class of drugs called immunomodulatory derivatives. The proteasome inhibitors, of course, the first generation is bortezomib or Velcade. I've shown here the side effects because these drugs all have efficacy, and many times our decision about which drug to select may be based not only on features of a person's myeloma behavior, but also on the side effect profile. And bortezomib can cause fatigue, GI toxicity, peripheral neuropathy, particularly when given IV or twice weekly, and usually a manageable decrease in platelets and white blood cells. Carfilzomib is the new kid on the block. It differs in its way it inhibits the proteasome. It does not have peripheral neuropathy as an advantage. It does have some low platelets, and at least in the US, it's approved to be given with quite a bit of IV fluids, which may be contributing to some shortness of breath that can be seen in some patients. The class of immunomodulatory inhibitors began with the story of thalidomide, which of course caused severe birth defects in pregnant women. All of these drugs have a risk of venous thromboembolism or blood clots that can be usually ameliorated by low-dose aspirin. Peripheral neuropathy is a problem with thalidomide. I would say it works, but it's hard to take because of the peripheral neuropathy and the sedation and constipation. Lenalidomide differs in just one sidearm, or Revlimid, but it gets rid of the unpleasant side effects of thalidomide, but it may cause low blood counts that need to be monitored, and it also has a risk of blood clots. Pomalidomide includes both of these sidearms, and even though it is more potent against the myeloma, its side effect profile is more like Revlimid than thalidomide, and it too can cause low blood counts and venous thromboembolism. Now, I just met with the Israeli myeloma group, and I think I have found it useful to try to orient people that are reading a lot about myeloma and different treatments in different countries to highlight the difference in practice patterns between Europe, Canada, and Australia, and I think what I understand for Israel, because in these countries, patients with myeloma are typically offered treatments based on age and general health into those who go on to receive high-dose therapy and a stem cell transplant as part of first-line therapy, and older patients or those with other medical problems will not receive a transplant but will receive chemotherapy. The issue of maintenance therapy with lenalidomide or bortezomib, particularly with lenalidomide, is controversial, but at progression, often lenalidomide or Revlimid and Dex is selected. In some patients, bortezomib-based treatment is selected. These are used to optimize their benefit in controlling the disease. When they quit working, usually the alternative class of drug forms the basis of treatment. And then there is this situation that is called double refractory disease, which has traditionally referred to myeloma that has progressed through both of these classes of potent agents. In the past, this might have been where the story stopped, but now for this group of patients, pomalidomide is approved in general all over the Western world. You have carfilzomib, probably bendamustine. We don't accept on clinical trial in Canada, and you can get some benefit of recycling the drugs that may have been used here in different combinations. In the U.S., and I say this mainly because if you keep up with results from the U.S. meetings, this distinction has been blurred, and many times patients are treated with a 3-drug combination at diagnosis, and then a decision for transplant is based on patient preference, physician preference. Maybe stem cells are collected, maybe a stem cell transplant is done at recurrence, and second-line therapy is much more heterogeneous. Maybe if the regimen of RVD, which is popular in the U.S., which is Revlimid, Velcade, and Dex, is used here, at progression, perhaps carfilzomib, pomalidomide are brought up to second-line treatment or third-line treatment. So what I'm going to focus on the next part is more the European-Canadian approach is managing current disease. In this, I'll also talk about second transplants because I think they have a role in selected patients, because really the treatment of myeloma these days until we cure it is to give sequential treatment in the most intelligent manner we can to milk all we can of control of the disease after each line of therapy, and of course preserve quality of life as much as possible. So this is a table that just summarizes the reports of second transplants done for relapsed myeloma, and I'm really just going to highlight our own data at Princes-Margaret. For many years our policy has been, based on our own analysis, is that as long as the first remission with a transplant has lasted at least 10 years, we will offer a second transplant at the time of first relapse after some reinduction therapy has been given. And this just shows our results that with that strategy, one can get a time to progression of about 1.5 years after the second transplant. And I won't show you the details, but if the first remission lasts more than 3 years, you get even a longer median benefit. Our bias is if this is done, it should be done at first relapse. Some of these analyses offered it at further in the disease course. I don't want to do in show, do I? Sorry. Okay. Further in the disease course, and I'm not sure you get the same benefit as using it second line. So that is our approach in selected individuals. And when we collect stem cells as part of induction therapy, we always collect enough for 2 transplants, even if we're not going to have an opportunity to use them in the future. Now, in keeping with talking about randomized trials, I've shown the older trials that really got drugs approved on the market because they had to show the new drug was better than the old drug. So what really made bortezomib available and approved was its randomized experience against high-dose steroids alone, where the time to progression was 6 months versus 3 months. If you add a drug to bortezomib, this was a chemotherapy called Doxil, you can improve that time to progression. These are medians, half of people longer, half of people shorter. And then the next major advantage was the documentation that Revlimid and dexamethasone versus dexamethasone alone will give close to a year median. And of course, what we hope with these regimens is we all see or have experienced that Revlimid and dexamethasone, I think we have people over 8 years still in remission when this has been used for recurrent disease. Now there's much interest in 3 and 4 drug regimens. The proof of principle, again, a randomized trial that suggests that 3 drugs might be better than 2 for relapse was a study from Italy. That randomized patients to Velcade thalidomide dex versus thalidomide and dex and showed that patients who had the 3-drug regimen had longer remissions and did better. I will hasten to say that not everyone needs 3 drugs for recurrence, but in this group of patients who had relapsed after transplant, there was an advantage. I think the problem with this is that Velcade was given twice a week with another drug that is hard on the peripheral nerves, and the grade 3 peripheral neuropathy was almost 30%. Nevertheless, there are a whole host of 3 and 4 drug combinations, and the point I want to make is that for recurrent disease, one can now expect overall response rates of 60 to 80% and complete response rates from 10 to 20, 25% in the recurrent disease setting, which is quite remarkable compared to what we saw 10 years ago or 15 years ago when the benefit of a transplant or melphalan and prednisone had worn off. There were not many options. What our group has done to try to optimize bortezomib, because Velcade's a great drug, giving it with steroids is useful, but we wanted to develop a 3-drug regimen that was as user-friendly as possible and we could give as long as possible. So in Canada, oral cyclophosphamide given once weekly has been a popular regimen with steroids even before novel agents. And a number of years ago, we combined it with bortezomib in a way that it's given once a week, like Monday, Monday, Monday. You skip a Monday and start again a month from the beginning. So your patient has 2 weeks where they don't have to come in to the hospital for an injection of bortezomib. What we found in this early phase 1-2 study is these are small numbers, but the overall response rate in relapsed refractory patients was over 80%, and the near complete remission rate was very good. We did not see any high-grade neuropathy, and we did not see really much thrombocytopenia. So we've adopted this as our 3-drug regimen for recurrence for those patients who need something more than lenalidomide and dex, or a 2-drug regimen for relapse. And we've just reviewed our non-clinical trial results in almost 100 patients to see what we've seen outside that pilot experience. There's also interest in retreatment with bortezomib. Someone who has it at diagnosis or who has it for relapse, can you, after an interim, introduce it again? And I would just point out that in our non-study setting, although our overall response rate wasn't 80%, we did have 2/3 of patients respond. Complete and very good partial remissions are 45%, whether a person had had bortezomib before or not. The median number of cycles given in this non-research experience, and these were all comers, people who presented or had been on dialysis. These are people who were very ill. These were not people that were screened for eligibility for a study. But the median progression-free survival was 15 months, and the median number of cycles given was 15. So we don't use bortezomib as a single agent or with steroids very often. We always try to combine it with a third agent if we're going to use it. And there are a variety of 3-drug regimens or 4-drug regimens using bortezomib and Revlimid as shown in this table. This is our study of Cybor-P. We now use weekly dex, which is more popular. And I think if you look at this, they're all highly effective. The 1-year progression-free survival, this is ours at 15 months. But I think you can get a lot out of optimizing bortezomib in this way. Sometimes we use RVD, but we tend to go with this regimen first. So I think one can discuss early relapse. I've already alluded to the options. In older patients who've had VMP, you can repeat a bortezomib-based regimen after a hiatus, and we more often use lenalidomide and dexamethasone. What about more advanced relapse? I've already shown you can go back to a drug, but now pomalidomide and dexamethasone is approved in Canada, and we have, even though it's not funded, we have it available through a compassionate program. Many of you are probably aware of the data on pomalidomide and weekly dexamethasone. This was a phase 3 trial, again required by the European and Canadian regulatory authorities to get it on the market. Patients were randomized to pomalidomide and weekly dex or high-dose dexamethasone alone. And I think one of the remarkable features about this trial, and Israel may have participated, we had a number of patients in Canada on this trial. The median number of prior treatments was 5. So this is a lot of treatment before patients went on this trial. And all had had the 2 most potent agents, lenalidomide and bortezomib. Most were refractory to both. And the drug worked in all of these situations. And I think the toxicity profile was reasonably good. Low platelets were not a particular problem. Fatigue, which is a tremendous issue with treatment of myeloma, was not higher with the regimen compared to dexamethasone. And I think an important figure to look at clinical trials is how many people had to stop due to adverse events, and it was relatively low. Anecdotally, and I would never pretend I know the experience of someone living with the disease, but many of our patients tell us they feel better on pomalidomide than they did on Revlimid, which I think is interesting. The progression-free survival was significantly better. It wasn't tremendously long for the whole population at 4 months, but people who did respond had remissions of 7 or 8 months. And what was particularly rewarding is in this very advanced setting, the median survival was over a year, which really adds a whole nother chunk of line of treatment to our armamentarium. I'll just make the point that the responses were seen in both high-risk chromosomal subsets and regular. Now, I think like the introduction of bortezomib, the future probably lies with pomalidomide in combination with other drugs, both new and old, to treat very advanced disease. There's an interesting regimen reported by Dr. Palumbo that uses oral cyclophosphamide every other day at a very low dose, given with pomalidomide and dex. And we have added cyclophosphamide, or given this 3-drug regimen, to people with very encouraging results. There are a variety of trials, and I've highlighted the ones that we're doing at Princes-Margaret Hospital. Pomalidomide is being studied with carfilzomib. We have a trial of pomalidomide, bortezomib dex for amyloidosis. Pomalidomide is being studied with dex and HDAC6 inhibitor called acetylon. And we hope to do a phase 1-2 trial of pomalidomide dex and a very interesting and potent new drug that we've been part of the phase 1-2 experience. I think the other uses will very possibly be in light chain amyloidosis, and one advantage of pomalidomide is it does not appear to be excreted renally. We've used it in patients with quite high creatinines. The data on its safety and efficacy in patients on dialysis is being formally studied by the manufacturer, but I think this will be a real advantage in the use of IMiDs in myeloma. I'll just say a brief word about carfilzomib. It too was studied in a very advanced population, not an arm and a leg different from pomalidomide. Response rates about 25% higher if minimal responses were included. Response duration, again, quite respectable at 7 or 8 months. And the survival with this drug in the very advanced setting was over a year, which I think is highly relevant in this setting. I'll just spend a couple of minutes on the future of myeloma, and there are so many new drugs out there. What I've chosen to do is mention the ones that were highlighted at the last American Society of Hematology meetings, I go back to this cartoon of the myeloma cell and the supporting cell and the environment, the stromal cell, and I've already mentioned that there are promoting factors released in the marrow to drive the myeloma cell so it has a survival and growth advantage. And now there are drugs that specifically can inhibit these different stages. I've named them here, but in an effort to really get at what lets the myeloma cell survive. Another very exciting avenue is using antibodies to fight a disease that makes antibodies. And in this approach, there are surface markers. This is my attempt to show different surface markers on a myeloma cell. And daratumumab appears highly active. It's an antibody against CD38 surface marker. The drug is attracted basically only to the myeloma cells, marks it for destruction by the immune system. And the attraction of these monoclonal antibodies is they're not chemotherapy, and they're generally very well tolerated. And monoclonal antibody therapy, analogous to this, has really revolutionized the care of lymphoma and breast cancer, and we've been looking for a similar drug in myeloma for a long time. The other monoclonal antibody that has been in clinical trials is one directed against a different surface marker called CS1 and elotuzumab. It's being combined with lenalidomide and dex. And another drug company, Sanofi, has a second product that is entering clinical trials. Daratumumab is now being studied with lenalidomide and dex. This was the pilot study, and it just shows that in heavily pretreated patients, this is the % change in the monoclonal antibody. And there is a trial now that's about to start internationally. I think Israel's going to participate. We're participating, where patients will be randomized to lenalidomide and dexamethasone, or lenalidomide and dex plus daratumumab. I'll summarize our approach. This is getting a bit redundant, but We often, for first relapse, will use lenalidomide and dex. I've talked about a second transplant. For second relapse, we will either add cyclophosphamide to this to create CRD, and we're just looking at our results for this approach, or we'll switch completely to a bortezomib-based regimen. Third relapse, if they haven't had bortezomib here, they'll get it here, pomalidomide dex. Occasionally we use aggressive chemo combinations to get patients in remission if they have very rapid disease, so we can transition them to a clinical trial. This is a busy diagram showing what I've just explained, and these are our current trials for relapse opportunity to highlight the new drugs that are out there for myeloma. There's an AKT inhibitor that's oral, made by GSK, that is very potent. OSI has an inhibitor of insulin growth factor 1. These are being combined with bortezomib. I've talked about this trial. This Karyopharm KPT-330 is a completely new class of oral drugs and is incredibly potent, has stabilized disease in a handful of people that have disease that have progressed through all this, just as a pill. The bromodomain inhibitors are a hot and attractive drug that are coming into clinical trials for myeloma, and we've just opened a study with a French company, Oncoethics, to explore this, and I've already talked about lenalidomide and daratumumab. So in summary, there are many options available. The sequence of regimens depends on a number of patient-related, disease-related, and treatment-related variables. But fortunately, most patients can receive all of the active drugs at some point in their disease course in some order. I think the future is incredibly bright for myeloma. The potent drugs of completely new classes are really at our fingertips, and I think it's incumbent on all of us in this area, both patients, physicians, funders need to work together to bring them to patients as the older treatments we have available wear off. Survival has improved significantly in this disease, and I think we all realize the importance of understanding the myeloma biology and heterogeneity of the disease that will lead us to offer personalized medicine and design strategies. And I'll just close with our commitment at Princes-Margaret is to bring the best science and treatment options to Canadian individuals with myeloma, and I can certainly see that that is the effort here in Israel with the physician community and with the wonderful work done by Amen. So thank you very much for the opportunity to speak here.
תודה רבה לדוקטור דונה ריס על ההרצאה המאלפת שלה.